Cardiology Update viewers and listener. I am Chadi Alraies, Director of the Cath Lab at Detroit Medical Center. I'm really privileged today. I will be talking about one of the hotline sessions that presented at European Society of Cardiology Congress, major meta-analysis and trial. The hot presentation was about OCT versus IVUS. Imaging, I think, and angiography was a major topic during the Congress. Multiple trials presented. But this is one of the landmark meta-analysis that was led by principal investigator, Professor Gregg Stone, who is a professor of medicine at Icahn School of Medicine at Mount Sinai, New York. Dr. Gregg Stone, thank you so much for joining us. It's a true honor to have you on the discussion today.
Thanks, Chad. Great to be here.
So this year, during ESC Hotline, 4 trials presented, 2 randomized trials, OCT-guided versus angiography-guided PCI were presented, October, as well as Illumian 4. Meanwhile, you put together a network meta-analysis integrating the data from Illumian 4 and October trial with prior studies as well to examine the effect of intravascular imaging guidance versus angiography. Can you tell us about the rationale behind your study?
Sure. Well, prior to this ESC, there had been many trials of intravascular imaging guidance during coronary drug-eluting stent implantation compared to angiography guidance, but most had been with intravascular ultrasound. And even with all the prior trials that had been done, they weren't powered even in prior meta-analyses to demonstrate whether or not intravascular imaging resulted in all-cause death or all myocardial infarction to be decreased. And so at the ESC, as you mentioned, it was unique. There were 3 new major OCT studies, the 2 that you mentioned, and then a comparative OCT versus IVUS study called OCT-IVUS, which came out of South Korea. And there was also one other IVUS versus angiography study called GUIDE-DES. So we felt it was time for an updated meta-analysis, and we performed a very comprehensive network meta-analysis, which allows us to look at the direct data of trials that were directly compared to each other, as well as the indirect data, which always requires some explanation for most people. They're not always knowledgeable about that concept. So the indirect data and a network meta-analysis gets to the concept that if Team A beats Team B and Team B beats Team C, would Team A beat Team C? And so you can use indirect data from the link between that trial to compare Team A and Team C. And you always like to see, it gives you a lot more events, a lot more data. You always like to see that such indirect comparisons are similar to the direct comparisons, the head-to-head randomized trials, which I'll go forward and tell you in our study they were. So it gives you a lot more power to look at these relationships.
Absolutely. So what's the purpose or the key question here comparing in general imaging to angiography guided or specifically OCT?
Well, we wanted to find out whether we knew from prior studies that overall major events would be reduced with intravascular imaging guidance. But we wanted to see now if with these additional studies we had enough power to say that actually all-cause death and all myocardial infarction was reduced. That was number 1. We wanted to understand the magnitude of stent thrombosis reduction with intravascular imaging. And then we also wanted to compare OCT and IVUS guidance to get a sense, OCT is relatively newer than IVUS. It has some, substantial advantages in terms of having higher resolution, better plaque characterization, penetration through calcium, but it's got less depth penetration through lipidic plaque. So it's got advantages and disadvantages as a guidance modality. We wanted to see if the study supported a similar or different results between IVUS and OCT guidance.
We did a coverage on the Illumian in detail, Illumian 4, and we know that it did not show a hard outcome difference in terms of myocardial infarction, but definitely show bigger lumen and bigger stent sizes and patency and some lower stent thrombosis. So now you put all these trials together. Is there any change in this outcome?
So I can tell you that from the ESC, we had a total of, the data that we presented at ESC was a total of 20 randomized trials in 12,428 patients. We had the Illumian 4 and we had the October data that we presented at ESC as part of this meta-analysis. That was 2 of the 20. We didn't yet have OCT-IVUS and we didn't yet have GUIDE-DES. Well, we've since ESC, updated the meta-analysis with those 2 additional trials and submitted it for publication. And I will just tell you that in general, the results are very similar to what we presented at ESC. So the bottom line is that we found that intravascular imaging, that is OCT or IVUS, compared to angiography guidance, was definitely effective in terms of enhancing both the safety and effectiveness of coronary drug-eluting stent implantation compared to angiography guidance. There was approximately a 31% reduction in target lesion failure, the primary composite adverse event for our study. But in addition, there was, for the first time ever, a substantial reduction in all-cause death and all myocardial infarction seen with these larger numbers of studies and larger number of events. So we saw a 25% reduction in all-cause mortality, which was driven by a 45% reduction in cardiac death. We had an 18% reduction in all myocardial infarctions, which were driven by a 20% reduction in target vessel myocardial infarctions. And what underlied a lot of that enhanced safety was stent thrombosis, which was reduced by 52% with intravascular imaging guidance compared to angiography guidance. And since you covered Illumian 4, you well know, most stent thromboses cause death or myocardial infarction. In fact, in Illumian 4, 96% of all the stent thromboses resulted in a death or an MI. So it's the most, major and devastating complication of stent implantation, purely iatrogenic. And so that's important to prevent.
Absolutely. And so, Dr. Stone, you mentioned 52 reduction in stent thrombosis. What were the predictors of stent thrombosis in the angiography group? Why are having more stent thrombosis there?
Well, stent thrombosis occurs with all stents and with drug-eluting stents. It's current drug-eluting stents. It's not increased compared to bare metal stents, but we haven't eliminated it. And while our study was not a mechanistic study, what we know is that the major reason that that imaging guidance reduces stent thrombosis is it improves the three major predictors of stent thrombosis, which is one, a small minimal stent area, and two, major edge dissections, and three, untreated focal reference segment disease. And all of those, multiple imaging studies, including Illumian 4, have shown are less with intravascular imaging guidance. And you just can't see a lot of these suboptimal results with angiography guidance alone.
Absolutely. So, Dr. Stone, this is phenomenal result, but as you know, the guideline published recently still listed imaging, IVUS and OCT, as 2B. Do you think this meta-analysis or the flux of trial that we have now will change the guidelines?
Well, they're actually 2A. It's actually a 2A recommendation. I think that, look, I'm not on the guidelines committee, so I'm not speaking for the guidelines committee, but in my opinion, it should be class 1. You now have a reduction in all-cause mortality and a substantial reduction, 1 out of 4 lives lost with angiography guidance, saved with intravascular imaging guidance, reduction in all myocardial infarction, huge reduction in stent thrombosis, as well as target lesion revascularization, about a 30% reduction in restenosis type events. And I'll remind you, coronary drug-eluting stents in the guidelines have a class 1 indication compared to bare metal stents. They don't reduce death, they don't reduce MI, they don't reduce stent thrombosis. All coronary drug-eluting stents do is reduce target lesion revascularization. And now we have intravascular imaging guidance that does that, but also reduces death, MI, and stent thrombosis. So it seems like if you're really comparing apples to apples, it clearly should have a class 1 indication.
Yeah, and that's what we hope for, because as you know, it's still in the US, the acquisition of imaging for PCI is not as we want it to be.
I agree. It's depending on who you listen to, somewhere between 15 to 20% of all PCI procedures. In Europe, it's less than 5%. But then in other countries like Japan, it's 95 to 98%. So, they open up an imaging catheter in every procedure. It's reimbursed. They train, their fellows how to do it, and it's just part of their routine PCI procedure. And South Korea now is up to 90%. So it definitely can be done. It's, just a matter of, I think, overcoming the remaining impediments to its use, which is better reimbursement and better training, both of the attendings and of the fellows.
Absolutely. So I think, as you mentioned nicely, Dr. Stone, is the knowledge gap, because we don't have enough fellows kind of trained to look at things, and also people who have been in practice, they are not familiar with the imaging findings. IVUS, I think they are getting more familiar, but OCT is becoming like a big, steep kind of knowledge gap there. But also the reimbursement part is kind of maybe one of the reasons why the inheritance of this device is not as much. Well, this is very insightful. I'm really excited. We go always to meetings and we talk about imaging, and I hope the listeners also take these results seriously and start to open for HPCI, open, as you said, an imaging catheter as soon as they call for the deflator or a stent. Uh, I would like to thank you, Dr. Stone, for your time. Really, thank you for your valuable time today. And thank for all the viewers and listeners to joining us today. Please visit cardiology-update.com and to social media platform to stay up to date for all new in cardiology. Dr. Stone, thanks again.